Well, good morning. So we'll be presenting, essentially it's two projects at two locations, but we're just going to combine them into the one presentation because they have very similar themes. And so what I'll do is I'll just set the framework and give you just a very quick background before I hand over to Francis to actually drill into the program detail and statistics, etc. So essentially what we set out to essentially look to identify service gaps and needs, clinical needs, areas of clinical needs in which our clinics are located, and then identify and embed the student placement opportunities as part of that process. So first of all, UQ Healthcare, a little bit of details about who we are. So it's 100% owned by the university. We're a not-for-profit company, and it was initially funded out of the GP Superclinic program. So we have and why is the university in this space, particularly in primary healthcare? There's an enormous amount of work, as many of you are probably aware, in terms of primary healthcare reform and much needed work. So the university essentially is in this space to create venues for high quality education and research, as well as for clinical innovation, but also to try to play something of a leadership role in that primary healthcare reform process, particularly at the primary care, acute care interface. So our clinics are located in, it's two super clinics. One is Brisbane South, which has two hubs, one at Annerley, right next to the PA Hospital, and one at Meadowbrook, a stone's throw from Logan Hospital, and we also have our clinic within the grounds of UQ Ipswich. Now when we set out to roll out our programs, it was essential for us that we engaged with the key stakeholders in both of our catchments, just to ensure the relevance of our program, that we were identifying needs and service gaps and creating services that are actually relevant, and we're going to meet those service gaps. So we had very high level representation from both Medicare locals in which we're located, so the West Moreton Oxley as well as the Greater Metro South Brisbane Medicare locals, as well as the West Moreton and Metro South HHSs. So we had high level representation from those groups, as well as from our faculty and schools representations, as well as other stakeholders as well. And as well as engaging them in terms of the relevance of our service delivery, the other component of that was with one eye on service sustainability with regard. Now, many of you, I'm not telling anyone in the room that in terms of multidisciplinary care in the community, Medicare is woefully inadequate in terms of funding that. So part of what we're doing in terms of this approach is to ensure that these key stakeholders were engaged right from the beginning, are fully informed of what we're doing and our outcomes and our successes, with a view to potentially tapping into some of those flexible funding sources that both bodies have access to from time to time going forward. So essentially we created the programs with a view to maximising the interprofessional component and the multidisciplinary approach to service delivery. Important to note there, we list medicine and nursing, although you won't see medicine and nursing in Francis's statistics. We have placements with our actual clinics. So we're looking to plug in medicine and nursing into our multidisciplinary programs at every opportunity, particularly motivated to get our medical students involved in IPE models in the hope that they might carry that forward into professional practice. As I mentioned before, we basically approached this with four core principles, definitely an IPE focus, so interprofessional education, and Francis will talk about how we went about doing that, with a service delivery focus, and our students are active participants, so effectively our workforce with regard to these programs under expert clinical supervision, and taking a health coaching approach with regard to our clients. So we're always bringing it back to making sure that patient is in the centre of what we're trying to achieve. And so we've got a range of programs that we are able to perform. It's essentially a generic pathway which Francis will show. And we've identified basically some launch programs that you can see on the slide. But that basic framework and template enables us to look at future potential programs, for instance, cancer rehab and smoking cessation programs, all those sorts of things that we can take a multidisciplinary approach and apply the basic template to. So essentially that's the framework for it. So I'll pass over to Francis to actually zero in on the actual programs themselves.
So just taking one of the programs, the Falls program, just to give you a feel for it, and we looked at looking at how we could have that so that there were different aspects for the student to engage in. So the students were involved in the program delivery in terms of the groups. Prior to any participants in the group, they were taking part in an interprofessional assessment. The students that you'll see noted there are OT, exercise physiology and psychology. What we thought was very important was that the programs wouldn't be necessarily designed around just specific one or two disciplines. So the IPE model for us was about engaging with those disciplines who were available to be on placement. Because one of the criticisms of previous sort of attempts at these programs was that the programs would stop when a certain discipline of students ceased their placement, or that the programs wouldn't have a continuity throughout the year. So in this instance we were able to engage with those specific placements, but of course that doesn't mean that there isn't room for other students such as physiotherapy students to be involved in that. The clients would then would also have access to individual disciplines, particularly dietetics and psychology, to name a couple of different ones, who they would have individual sessions with. And that was in relation to our UQ partners, Cheryl Collins providing the dietetics component there. The Falls program, we also had an in-reach component with the residential aged care sector. So working with Blue Care and Tall Trees in the Metro South area, the students would deliver the programs with a clinical supervisor in those settings, and that's looking like it has a scope to grow. I guess we'll talk more about it, but then clearly we wanted to embrace that cross-referral process into other aspects of what we were doing back on the previous slide, like the continence program. So where other aspects of the client's care was picked up, the students have the capacity to refer into those other programs. The Healthy Ageing program wasn't one of the earlier programs identified, but it's proved to be one where the clients are heavily engaged, and so it's giving the students, particularly EP students at this point in time, a strong client base to work with. So this just gives you a feel for the client journey through the program, and this is where Daryl mentioned that this would be this is a generic process which we obviously adapt for each program. Looks slightly different in terms of particularly the other stakeholders and partners and referral pathways, but as an overall glance, this gives you a feel for how it works. I guess importantly, the clinical supervisors who we've worked with have been extraordinarily committed to our process, and those clinical supervisors might have a job share where they are also based either in the private sector, working with Queensland, one of our Queensland health partners, or other non-government agencies. So we've found that that's been a really rich source of collaborating by working with people who are linked into other partner agencies. The clinical supervisors clearly have supervised students from their own discipline, but also students from other disciplines in that IPE model we'll talk a bit more about. So the placement model itself, I keep going on about IPE, so the initial assessment was a key framework for that, and also then having case conference. So pairs of students would undertake the initial assessment, which was designed with the working groups assisted with the design of that, and it might be that their different students on different days could be part of that. So on one occasion it might be a psychology student working with an exercise phys student, on another day it might be an OT student working with a dietetic student, but at any one time those interprofessional initial assessments could be going along, even if we didn't have an OT on placement this week, there wasn't a stop to that. The health coaching, just to make a comment on that, that was an important part of having some principles around which shared disciplines, that could be shared across the different disciplines. So where the client was at the focus of things and that goal setting was around the client's health needs. There's been some discussion around different alternate models, and I suppose we found ourselves doing block placements, shared placements, sessional placements, to name a couple. Clearly the scheduling was challenging, and I've mentioned a couple of times the fact that students might come and go and we wouldn't necessarily always have all of the same students. And the other part of it was that was challenging and needing to assist the clinical educators to be understanding and having a strength across the fact that the supervision requirements and the assessment requirements of different disciplines varied, as did they at different universities. The benefits to the students were looking at working in that primary healthcare setting where they had access to being part of a team delivery to an in-need client group. So to date we've had 581 student placement days in this model. Oh, beg your pardon. It's small on my screen and I can't read that. So, but that just gives you a breakdown of the different disciplines involved to date and in terms of number. Yeah. So Ben, for example, was a student from one of the other universities. We mention UQ a lot. UQ's in our name, but there have been students from Griffith, University of Southern Queensland and QUT as well. Just a couple of key points around the supervision model. I think I mentioned before the commitment of the staff and the willingness of the staff to take on board supervising students from other disciplines and to become skilled in that and wanting to learn about what that looked like. The other very important part of this was the link and the partnership with the university, and Amy and Lucy are two of the people here from UQ. And that's just been essential in terms of them having the trust in us to give this model a go. Clearly, you know, there needed to be trust around how we would ensure that the students got an adequate learning experience in a new model like this. I won't go on about the tools, and there were a lot of resources have been developed through the process as well, but this particular tool was the one that we adopted from the MARTA. So in terms of the viability of the model going forward, oh my goodness, sorry, that's a bit quicker than I can't read this up front, but I guess in terms of the viability, I guess there are a couple of main things that we have been focusing on. One is Darryl mentioned that most of our funding comes from Medicare. And that therefore we don't have access to a lot of funding for allied health as such. So we wanted it to be an affordable model which would have the capacity to continue. As part of that, we're continuing to work with our partner group, but we're also working with clinical specialists, medical specialists, to grow the model such that we have a referral pathway from GPs to medical specialists who can bulk bill, and then or bill Medicare, and then we have a pathway for actually retaining some of that funding to go towards the allied health and the IPE component. That's sort of in a nutshell. You might have guessed I'm short-sighted, so I can't come in between the two. So this just gives you a bit of a flavour for some of our statistics at this point in time. We've had 156 session rating scales have been done to date, and the outcomes of those is that it's at a 94% of rating of 80% and above in terms of satisfactory or very satisfactory, and 100% of the clients who have participated in the program have actually indicated that they are 100% satisfied. Sorry. I'm just going to turn this sheet so that I can see. So we've conducted 231 IPE assessments to date, and there have been 171 individual discipline-specific assessments. So that just gives you a sense of the volume of work that we've been able to achieve by having the student cohort involved. And we've had done 111 group programs across falls group, diabetes groups, and the healthy ageing group, and also cardiac rehab. In terms of the early outcomes from the student group, we've took the pre and post assessments of 16 students across 6 disciplines. They're indicating that the teamwork skills are essential for all healthcare students. They're in agreement or strong agreement with that statement, and also that individuals in their professions need to cooperate with their other professional partners. That research is continuing, and towards the end of November we'll have a broader base of information to share with you. So I think we've already touched on these, most of these numbers. The slides are just moving a little bit around. So I guess the essential messages are about working in collaboration with others who have got a common goal. So in our case, the identified area of need was around clinical need, and then the need for student placements and student learning opportunities. So where those two things came together with the commitment from the expert clinical educators and the willingness to modify the model as we went along. Oops, sorry. So where to from here? We're looking at consolidating the programs and starting to embed the student role even further, and some of the information talked about earlier about looking at those competencies and ensuring that students have got those. That's work in progress for us. We are wanting to confirm routine student placements so that we have, I guess, a little bit like the rolling model, but that we're looking at having placements going throughout the year, and building that pathway to direct GP referrals and direct relationships with those medical specialists. Thank you very much.